uropathies, they can have later impact in life. And of course, the kidneys are very important. They can affect renal function, and they can affect the outcome of these children, adolescents, and adults later in life. This study, that was a very large study coming from the Fetal Medicine Foundation, was about the detection of anomalies at the scan that you are performing between 35 to 37 weeks. And this is becoming a very important scan. To be honest, in my opinion, we have to provide for everybody a scan around 36 weeks, not just for the diagnosis of malformations that you are not seen before, but of course for the follow-up of malformations that you are seen before, but especially to check fetal growth abnormalities. And this is the best time to make the diagnosis of late onset fetal growth restriction, and of course the cases of large for gestational age and macrosomia, especially when there is diabetes. If you look at this table on the left side of the screen, you can see that hydronephrosis and unilateral dilated ureter, they are most commonly diagnosed in the third trimester. It means that they are evolving anomalies that sometimes is not present at 20 weeks, but they can be detected in the third trimester. And this is important, as I mentioned before, in terms of follow-up. Around 6% of the cases of hydronephrosis, they are only detected in the third trimester, and the Isuog guideline was very clear about that. One important point, what's the cutoff when we are measuring the renal pelvic anterior-posterior diameter, or the IP diameter in the third trimester. This has to be less than 7 millimeters. Recently, with the publication of the Isuog guideline for the performance of ultrasounds at 20 weeks at the time of the morphology scan, we changed the cutoff from 4 to 5 millimeters to 7 millimeters as well. And this is the cutoff that you are using during the whole second half of the pregnancy at this point in time. When the renal pelvis is measuring more than 15 millimeters, there is a high association with increased risk for the necessity of a procedure after birth. If this is not performed, increase the risk of future renal impairments for these kids or for the adults. Dilatation of the renal calyces and the thickness of the cortex, they always should be checked if there is the case of renal pelvis dilatation or hydronephrosis, because they are prognostic factors. Here, one example of a normal kidney in the third trimester, that you can see the normal pyramids, that they appear anechoic. And this one example of a hydronephrotic kidney, where the renal pelvis is dilated, more than 7 millimeters, here much more than that. But also you can see calyceal dilatation in this kind of case, and the parenchyma is slightly echogenic. Another important thing in terms of the diagnosis of hydronephrosis is to follow the lateral ureter, or the same side ureter, in order to check if there is an obstruction of that, and I'm going to talk with more details about that during this presentation. But there's another point that I mentioned before. Some anomalies, they are present already in the first or the second trimester of the pregnancy, but for different reasons. One of them is ultrasound with not very trained operators. The other one is fetal position at the time of that scan. And another one that's quite frequent nowadays is patients with high BMI and difficulty in the ultrasound in the first and second trimester. It means that in some cases, besides that the anomaly is already present there, is just visualized in the third trimester. I'm going one by one to the most frequent renal anomalies in order to discuss them. I'm starting with horseshoe kidneys. Horseshoe kidneys, is a relatively easy diagnosis that you can see that the kidneys are united by the inferior poles. Here, there is in yellow showing the format of these kidneys, and you can see the renal pelvises that they are evident here. Horseshoe kidneys, they could be associated with genetic anomalies. 30% of the cases of Turner syndrome and 20% of the cases of trisomy 18 horseshoe kidneys are present. Also, there's some associated anomalies, and one that's besides is rare could be associated with that is caudal regression syndrome. Other defects includes hydronephrosis and genital anomalies. Extra anomalies coming together with horseshoe kidneys, they can be present in around 30% of the cases. In terms of prognosis, when it's isolated, the prognosis is very good. What's advised is to check the presence of hydronephrosis that can increase the risk of future urinary tract infections and lephrolithiasis in this kind of cases. Another common anomaly that we can see very easily at the time of the 20-week scan, but sometimes we are making diagnosis only the third trimester, are multicyst kidneys. Here is a classical example that you can see an enlarged hyperechogenic kidney with multiple macrocysts. However, have a look in this kidney. This kidney is atrophic, but the case of the atrophy was multicyst kidneys as well, that you can see microcysts. And then this kidney is highlighted in the same fetus. You can have different presentations even in the same fetus. There is a small association between multicyst kidneys and trisomies. There is a weak association with trisomy 18. Most of the times they are bilateral, and bilateral ones, they can happen in 15% of the cases. Other associated genetic syndromes are found in around 10% of the cases. In terms of prognosis, when it's bilateral, this is lethal, and most of the renal anomalies that they are interfering with the production of amniotic fluids, they're causing pulmonary hyperplasia, and this is the most common reason for lethality after birth. When it's unilateral, it's a very good prognosis. Normally, the urologists postnatally, they have a expectant management because most of these kidneys, they are gradually shrinking, and eventually they become so small. In rare cases, they can become big, and it's necessary a surgical removal of these kidneys. Another anomaly is the presence of pelvic kidney. This is the normal ultrasound appearance of a kidney in the renal fossa, and in the same fetus, you can see this mass with an anechoic central area that actually is a kidney with the pelvis with a mild renal pelvis dilatation that helps to make the diagnosis. Sometimes the kidney could be pelvic, and we can have difficulties to identify by ultrasound. This is the reason in the case of unilateral renal agenesis, we always put the question mark that eventually this fetus could have a pelvic kidney that you cannot detect by ultrasound. The incidence of chromosomal defects and genetic syndromes is not increased in this kind of cases. The prognosis is pretty good, increases slightly the chance of vesical ureteral reflux, uretary pelvic junction obstructions in this kind of cases, but this is less common. Postnatal follow-up, it's important to make sure that it's not happening postnatally or during childhood. Another, and now a bit more rare anomaly, is the autosomal recessive polycystic kidneys. This is the classical example of the fetal presentation of that you can see both kidneys, very enlarged and echogenic, presenting microcysts, different than the macrocysts in the multicystic kidney disease. This is in highlights that you can see both kidneys very increased in size with the presence of anhydramnios because they are not producing urine. The incidence of chromosomal abnormalities and genetic syndromes is not increased in this kind of case, but of course, this is a lethal condition that could be intrauterus during fetal life or could be in the early neonatal period. Some cases, they have infantile and juvenile types, that there is evolution for chronic renal failure and could be associated with hepatic fibrosis and portal hypertension. Some cases, they can survive to the teenager age, and then this kind of cases, they require renal transplants in order to save the lives of the teenage or adults that has this issue. Some examples of cases that you are seeing in my hospital at the Gold Coast University Hospital that they are associated with renal anomalies, and sometimes you have the suspicions, and and the evolution is benign. This is one example of bilateral, a little bit enlarged hyperechogenic kidneys that you can see here. We made the suspicious of eventually microcystic kidneys. But the evolution, you can see that along the time, the appearance, besides they are a little bit bigger than supposed to be, a little bit hyperechogenic. Along the pregnancy, the evolution was better. And at the end of the pregnancy, the appearance was nearly normal. And this fetus had a normal outcome without the presence of renal anomalies after birth. Another example I mentioned before is renal agenesis that you can see when it's unilateral, one normal kidney in the renal fossa, and then in the contralateral sides, we cannot see it. In this kind of case, we have to check for a pelvic kidney, and sometimes you can find, sometimes you cannot find it. In terms of prognosis, when it's unilateral, of course, it's a very good prognosis. There is a small association with trisomy 18, and associated other syndromes happens in around 10% of the cases. Bilateral, of course, is a lethal condition. When it's unilateral, has a very good prognosis. One example that we saw recently in our center that you can see a normal right kidney, and then we can see the aorta. In this kind of case, we can see the right renal artery. In the contralateral side, we cannot see the left renal artery, and you can see empty left renal fossa that you can see right kidney here, and you cannot see the left kidney. And this was a diagnosis for the first time at 33 weeks of pregnancy. The most common renal malformation that you can see in the third trimester is hydronephrosis. Classical example, this is a transverse view of the fetal abdomen with spine up. We can see a normal kidney with a normal renal pelvis and then a dilated pelvis. The way to measure is the anteroposterior diameter of the pelvis, and I mentioned before that the cutoff is less than 7 millimeters. If above 15 millimeters, increases the risk of the necessity of postnatal treatment. Calyceal dilatation, and you can see this in yellow, showing where there is accumulation of urine in the kidney. Chromosome defects is low risk when this is isolated. We have to check, of course, the contralateral kidney. If the contralateral kidney is normal, the prognosis is much better, but I can have bilateral issues. The association with other genetic syndromes is low. That happens in around 5% of the cases. Majority of the cases, especially the mild to moderate, they resolve spontaneously during the fetal life or early neonatal or infant periods. About 20% of the cases, there is underlying uteropelvic junction obstruction or vesical ureteric reflux that's necessary treatment after birth. When there is moderate hydronephrosis, it's usually progressive, and around 50% of these cases, they need postnatal surgery up to the 2 years of life. Another very common anomaly is uteropelvic junction obstruction, and of course, this is a case of hydronephrosis. You can see a normal pelvis in the left side that's less than 7 millimeters, and a mild dilatation in the side, and then you can see the classical example that's obstruction or stenosis of the ureter very close to the kidney. The incidence of chromosomal anomalies is not increased in this kind of cases. Of course, you have to check the contralateral kidney. In the majority of cases, they have very good prognosis. Few cases, they need intervention after birth. Another example that was a diagnosis made for the first time at 30 weeks of pregnancy, that you can see the right kidney with severe renal pelvic dilatation, and then the contralateral kidney with mild dilatation. We can see calyceal dilatation here, and then in this video clip, you can see this hydronephrosis that's quite prominent in the right kidney, and here, yeah, sagittal view of the kidney. It's very easy diagnosis, the other normal contralateral kidney. And again, another case that diagnosis was made for the first time in the first trimester of the pregnancy. Ureterovesical junction obstruction, of course, this is the obstruction at the point of the connection of the ureter with the bladder, causing as well hydronephrosis, but then we have a dilated ureter. That's not the case when there is obstruction at the level of the kidney. We can follow up the ureter up to the bladder, and you can see the dilated ureter going to the bladder. It doesn't increase the association with chromosomal issues, and the prognosis generally is a very good prognosis, and as some cases of the uteropelvic dilatation, it increases the chance of necessity of treatment after birth. One case of duplex kidney, and finalizing my presentation, that you can see a mild dilated pelvis here and a normal pelvis. But when you're falling at the ureter, you can see dilatation of the ureter in this kind of case, and then we can follow the ureter up to the bladder. This is related with reflux. Last thing that I can show you is urethral obstruction. This is an easy first, second trimester diagnosis, but sometimes the patient didn't have a scan early as a reason. But the classical example is a mega bladder with the keyhole sign. And of course, there's a large association of this kind of obstruction with the most common chromosomal anomalies, and other defects can happen in up to 40% of the cases. The prognosis, there is a high perinatal mortality secondary to oligohydramnios, sometimes anhydramnios, and the consequent hypoplastic lungs. To finalize my presentation, just another example that we made the diagnosis at 31 weeks of pregnancy, that you can see mild left renal pelvic dilatation, but the right ureter was very dilated. Here is close to the bladder, quite dilated on the right side, and then you can see the connection with the bladder in a case of uterovesical obstruction. Mild left kidney dilatation, but a mega ureter on the right side that could be easily seen by ultrasound, another diagnosis that was made in the third trimester. The take-home messages of this presentation that some fetal renal anomalies, they only become detectable in the third trimester, and this is the importance of the third trimester ultrasounds. It's very important to make these detections and to provide counseling for the parents of these anomalies and for postnatal follow-up. And it's important to emphasize that there's a variation in terms of outcomes, some with very good outcomes, and some of them needing postnatal treatment, and some of the cases of severe obstructions with oligohydramnios and anhydramnios, they could be lethal secondary to pulmonary hyperplasia. Thank you so much.
Thanks very much, Fabrizio, for a fantastic talk, and it's prompted a couple of questions which will come to the very end, Fabrizio. But I'm interested to hear when you talk about a unilateral renal agenesis that it has a 10% association with aneuploidy, whereas a pelvic kidney there's none. And I guess I want to, at the end, ask you a question whether you would offer invasive genetic testing for an isolated kidney in the setting of a low-risk cell-free DNA. But we'll come to Q&A at the end. And the other relevant point, in a sense, you make is kidneys are just very hard to see sometimes, particularly in patients with large BMI. And then we're faced with this challenge of a unilateral finding late in the pregnancy. And do you offer invasive testing? But again, a great talk covering the entire A to Z of renal tract anomalies in the third trimester. So next we move on to Asma. Asma needs no introduction. She's extremely active in the field of education. She's a professor of ONG at St. George's, director of fetal medicine at Liverpool Hospital, a trustee on the board of Isuog, very widely published. I don't know of anybody who's published as widely as Asma for her stage, and don't call it training, but a stage in her career. And is the vice president for academia and strategy at the college. So Asma wears many hats and is extremely active in the field of education. So in the terms of putting the program together, there are three sort of very relevant things that we see in the third trimester that are challenging. And again, Asma has published on all of these, and just the right person for the job to cover the topic of achondroplasia, bowel obstruction, and vein of Galen. Asma, over to you.
So dear colleagues and friends, this talk will cover vein of Galen, achondroplasia, and bowel obstruction. What are the links? Is the link between the three anomalies? Well, they all usually diagnosed often in the first time in the third trimester. So the instance of fetal anomalies detected or diagnosed or seen in the third trimester, according to this screening study that was performed routine ultrasound scan, about between 35 and 37 weeks, was about 2%. If you look at this 2%, about nearly 70% or 2/3 of these cases were already diagnosed in the first or the second trimester, but a quarter of these abnormalities were diagnosed for the first time in the third trimester, and about 7% were only detected postnatally. And there's always this question about what is the value of detecting fetal abnormalities in the third trimester. And there are a number of potential benefits, including improving the postnatal outcomes. So, for example, some of these abnormalities, if you identify prenatally, you will make sure that you plan the delivery at a certain time, and particularly at a place where there is the facility for maybe immediate peripartum intervention, or maybe doing postnatal investigations. And in some cases, you could actually offer a fetal intervention that could improve the outcomes. And of course, we mustn't shy away that there will be some cases where there is potential option of termination of the pregnancy. So the vein of Galen aneurysm diagnosis, again, usually in the third trimester, diagnosis is really easy. It's an axial view of the fetal head, and you see the supratentorial midline translucent elongated cyst. And the key thing, when you put the color Doppler, when you see this active arterial venous flow within the cyst. So the diagnosis is really easy. And why is important? It is the most common CNS vascular abnormality detected prenatally. The incidence is about approximately 1 in 50,000 live births, and this constitutes about 1/3 of pediatric congenital vascular anomalies. The embryology of the vein of Galen aneurysmal malformation really stems from the fact that it is arteriovenous fistula. So the main drainage of the choroid plexus, and this is a really nice article. And in this figure, you see this is the median prosencephalic vein of Markowski. And normally, this is anterior, is posterior. Normally, the anterior part will actually should regress, and the dorsal segment will develop into vein of Galen in adult, like what you see in adult. But in cases or fetuses where they have the vein of Galen or develop vein of Galen and arterial malformation, what happens is that really early in the pregnancy, in the first trimester, around 6 to 11 weeks, there is this disruption in the early embryological pathway of these cerebral vessels, and that leads into this arteriovenous fistulas between the choroidal circulation and this prosencephalic vein of Markowski. And therefore, that obviously leads to a shunt of the fluid and a result into the ultimate formation of the vein of Galen arterial malformation. And is it inherited? Well, not usually, and the risk of recurrence is not increased in future pregnancies, but certainly there evidence to support that it does have genetic origin. So in this paper, there's de novo mutation in chromatin modifier genes and the Ephrin type B receptor 4, and this is now considered as or seen as probable significant genetic contributions to the development of vein of Galen arterial malformation. There are two morphological types. It's more we don't really see it on a prenatal ultrasound scan, but that potentially explains why some cases more likely to have heart failure and some cases don't. So this is the choroidal type, where actually see many choroidal arteries open into the venous pouch, and that's resulting in heart failure in most of the cases. While the mural type, where there is simple arteriovenous fistulas in the wall of Galen vein, and that rarely actually causes severe intrauterine symptoms. So what is the problem with the vein of Galen arterial malformation? Well, the fact that they have this hyperdynamic circulation, and therefore that can result in heart failure and fetal hydrops. Some of this case, about a third of the cases, they will have ventriculomegaly, and that's because of the increase in the venous pressure, so that reduces the CSF resorption, but also the fact that there's compression and obstruction of the salvia of the aqueduct by the dilated vein of Galen. And also the fact that they can have secondary brain lesions, and that because of chronic venous congestion and ischemia, and that can cause destruction of the white matter. And in the ultimate form, we have this melting brain syndrome, where again, as a mechanism, as I mentioned, is chronic venous congestion and ischemia that leads to destruction of the brain tissue and volume loss of the periventricular white matter, which is a key really diagnostic feature in melting brain syndrome. As you can see in this MRI images from two cases, we have this, you have the type, the vein of Galen malformation, there is ventriculomegaly, the dilated torque, but here the key is they have this loss of volume, reduced volume of the periventricular white matter, and the same in this case, again, in this it's reduced volume of the periventricular white matter, the melting brain syndrome. I mentioned earlier that this the hyperdynamic circulation lead to cardiac changes and ultimately heart failure. So, and therefore, whenever you have vein of Galen, you need to look at the heart and even do a fetal echo, because there are a list of cardiac changes that you could come across in the form of cardiomegaly, in the form of the dilated right side of the heart, there's the tricuspid regurgitation, the dilated, markedly dilated vessels like the superior vena cava, the jugular vessels. There is impaired right ventricular systolic function, and you see the reverse flow in aortic arch. How common are the associated ultrasound abnormalities or findings? In the ventriculomegaly is reported in about a third of the cases. The cardiac change is about a quarter of the cases, and in extreme form, obviously hydrops was associated with increased perinatal mortality. Most of the cases, about more than 70% of the case predicted prenatally. The prognosis is it is divided into 3/3. 1/3 of these babies die, often postnatally, and 1/3 they survive and they have good outcome after postnatal intervention, and about 1/3 they survive but they have neurodevelopmental delay. And therefore, once you make the diagnosis, and the diagnosis is very easy, because you have this big cystic structure in the midline and the axial view of the fetal head, you put the color, and then now you need to define sort of to do detailed neurosonography or MRI, looking for associated brain abnormalities or lesions, echo to look for early signs of heart failure. How often should I see this patient? Weekly ultrasound, because you're looking for the signs of heart failure or deterioration. And if you have hydrops, that's obviously a sign of very poor prognosis with high mortality. And in this case, you should be delivering around 38 weeks by cesarean section. Very importantly, in a place where obviously you have neonatal unit facilities and specialist pediatric neurosurgery, because they require postnatal intervention. A number of studies looked at or reported about the prognostic features, and of course, if you have associated brain lesions, it's the prognosis is worse. If you have tricuspid regurgitation, and then some studies sort of reported contradicting results. Some said the diameter of the straight or falcine sinus is predictor. Obviously, the larger the worse outcome, and some suggested actually the volume of the vein of Galen. Until a few years ago, a couple of years ago, the treatment is mainly, or the intervention is postnatally in the form of embolization of the vein of Galen malformation. This was the first report of a fetal intervention come from the United States, from the Boston Children's Hospital, of actually ultrasound-guided transuterine embolization of the vein of Galen. And in this case, successful outcome, did not require postnatal treatment, and the outcome was very good. And the team led by Darren Orbach went on to have set up the study. This is a protocol, it's published, it's a prospective, it's a single arm, it's non-randomized intervention study. And that means to assess really the safety and efficacy of this intervention, which is in the form of embolization of the vein of Galen malformation. It started recruitment on the 30th of September 2022, expected to complete recruitment in 2025. And the technique, as you can see on the right side, this is an MRI image where basically ultrasound guided. You pass this needle, 19-gauge needle, transuterine. You go to the confluence of the sinuses, and that allows you access the varix, and through that you pass. So this is the red is a needle, and then you pass the microcatheter, which is the blue, and this microcatheter will allow you to deliver the coils, which are in green color, and this is a coil for embolization. About a few months after that, about 6 months after the publication by the American team, and the French team published another case where they had a prenatal treatment of vein of Galen. This case required postnatal intervention, but the baby survived. It was a good outcome. And we published this paper in White Journal a few months ago, where we actually looked at the literature, but also reported this case from Poland, from the team led by Robert Sameha, where this case was referred at 26 weeks. This is a vein of Galen malformation. You can see the size is just about under 2 centimeters. There's already cardiomegaly, already the dilated vessels, the jugular veins, superior vena cava. This is the MRI image of the vein of Galen malformation. As you can see, there was no ventriculomegaly. There were no associated brain abnormalities. And 29 weeks has progressed, so the size of the vein is increased. And also there was early signs of heart failure. A week later, there's early signs of hydrops. And the mother, despite being non-intensive, started developing perhaps early signs of maybe potentially Meyer syndrome and raised liver enzymes. And at that point, because of also the early signs of hydrops, there was an MDT, and there was a decision for offering fetal intervention. The technique is similar to the technique that was described by the American team and the French team. In this case, they had general anesthetic. The other two was epidural, spinal, intramuscular anesthesia for the fetus, and ultrasound guided. You pass the needle here. You go into the sinus confluence, and you pass this microcatheter, and through the microcatheter you deploy these coils, and these coils are used for the embolization. In this case, they put 12 detachable coils. 48 hours post-operative, it was successful. Surgery in terms of decreasing the blood flow in the vein of Galen malformation, improvement in fetal cardiac function. but the mother starts developing what we like health syndromes by being hypotensive. This raised liver enzymes, there's raised lactate dehydrogenase, LDH, and also very high SPLA1 ratio. And unfortunately, the following day, there was a diagnosis of intrauterine fetal demise, and the further one was induced. This is a post-mortem X-ray and autopsy, and you can see the coils here in the correct position. And the mother obviously developed hypertension after delivery. So successful surgery, but unfortunately, baby died. In this paper that we published, we did really wanted to highlight that the literature could potentially be biased because only really cases with good outcomes get published. Well, what about the cases that actually have bad outcome? And highlighting these two published cases that were presented in FMF World Congress in June 2023 by Rogelio Cruz Martinez, published its reported or presented these two cases that had successful fetal intervention, same technique, but unfortunately died postnatally due to renal failure. In this paper, we did compare really the fine details of these two cases, the cases from the United States and the cases from France. I'm not going to go through it because of the time. I'm going to move on to achondroplasia. And achondroplasia, it is the most common non-lethal skeletal dysplasia and result because of mutation in the FGFR gene. It does have autosomal dominant inheritance and is often can be diagnosed by doing amniocentesis, testing for the gene mutation, or actually nowadays you can do non-invasive maternal self-read DNA in the maternal blood. Of course, it's autosomal dominance. You need only one abnormal gene, and that's the heterozygous. And these children tend to be dwarf, but they have normal intelligence and life expectancy. They can have morbidity. They have stenotic vertebral canal, but now there is a trial of postnatal treatment. But if it's homozygous, if the two parents have achondroplasia and they pass the faulty gene, that means it's homozygous, and these cases are lethal because of the severe pulmonary hyperplasia. What about prenatally? Well, obviously, most of the cases are diagnosed in the third trimester because this is where you actually see the severe shortening of the long bones for the first time. And but only about a third of the cases, the femur is also bowed. A majority, 90%, they have frontal bossing. They can have short fingers, a trident hand, and about 70% of them, they have large heads, and a third the cases have small chests, and about 2/3 of the cases, they could also have polyhedramnios. I think one feature that I'd like to highlight in this talk is the fact that the fetuses with achondroplasia, they tend to have a wide proximal femoral angle. So this is in normal babies, and you see this angle compared to this angle. So in babies with achondroplasia, you see it's much wider or much more obtuse. And we published this study about 10 years ago. We reported that fetuses with achondroplasia at the time of the diagnosis, if you measure this femoral proximal diaphysis between the diaphysis and the metaphysis angle, it's much wider or obtuse compared to controls, so normal fetuses, or compared to other fetuses that could be in similar situation. They have short femur in the third trimester. There's a cohort of trisomy 21 and also a cohort of skeletal dysplasias. And if you, between trisomy 21 and the normal fetus or controls, there's no difference in this angle. Again, between skeletal dysplasia and no controls, no difference. While actually achondroplasia, when you compare to other types of skeletal dysplasia, like somatophoric dysplasia, or Jones dystrophy, or osteogenesis imperfecta, the angle was much wider. We went on and tried to see whether we can actually use that as a marker in the second trimester. So at 20 to 24 weeks, for the time often the femur is still within normal range, is this angle tend to be wider? And the answer is yes. In this research letter, a small number, so it needs to be obviously validated in a larger cohort, but actually this angle with wider in fetuses when had diagnosis of achondroplasia later in pregnancy compared to normal fetuses. For achondroplasia, if it is a de novo mutation, the risk of recurrence is low, but actually if one of the parents affected, the risk of recurrence is 50-50, and if the both parents are affected, the chance of heterozygous, so affected baby or fetus about 50%, but of course if both of them pass on the 40 gene, that means homozygous, chance is 1 in 4, and that's lethal, as I mentioned earlier, and about 1 in 4 the fetus would be unaffected. Moving on to bowel obstruction, which is the last part of this talk, and highlighting that there are typical features or ultrasound diagnostic criteria of bowel obstruction, which are common, so dilated bowel, polyhydramnios, or both. But there's also the atypical or uncommon diagnostic criteria or ultrasound features that you need to be aware of in the form of meconium peritonitis, meconium pseudocyst, and ascites or hydrops. Very important basic sort of feature or basic fact, how you differentiate between small bowel and large bowel on ultrasound scan. Well, obviously, small bowel have a smaller human caliber, the plicae circularis, the fluid content, and obviously the peristalsis. So those are features. If you have a dilated lobe of bowel, it's a small bowel or large bowel. How do you define actually dilated bowel? Do we have a reference range? And the answer is yes. So in this study, see, obviously it varies with gestational age by diameter by 42 weeks. Small bowel, the average about 5 millimeter and maximum is about 8 millimeter. The large bowel is about average is 15 millimeter, maximum is about 19 millimeter. Very important is the fact that the longitudinal changes. So in this study, you see that in fetuses with suspected dilated bowel, if you follow them up, the one that were stable or even regressed had no bowel pathology, while the one that progressed is the one that had the bowel pathology. So importance of doing longitudinal assessment and follow-up ultrasound scans. So in this study, the one that had a normal neutral outcome in about more than half the cases, actually the bowel dilatation resolved on follow-up scans, while the cases that had progressive dilatation, they all had pathology needed postnatal intervention. Then, what about the presence of polyhydramnios? Is it a reliable marker or feature of bowel obstruction? Answer is not. And in only present about half of the cases of jejunal atresia and about a quarter of the cases of jejunal ileal atresia. So it's not really a reliable feature on ultrasound scan. And how good is the prenatal ultrasound scan in diagnosing jejunal or ileal atresia? We published this paper again about 9 years ago. The detection rate for jejunal atresia is only about 66%, and ileal atresia is only about 25%. So, but certainly the most reliable feature if you have a combination of dilated bowel and polyhydramnios. What about pyloric atresia? So in this case, you have a dilated stomach, you have polyhydramnios, and be careful because the possibility of genetic abnormality, particularly something called Carmi syndrome, which is a result because of the mutation in the IGTP4. In this case, you have pyloric atresia, so you have dilated stomach, you have the polyhydramnios, but important, the polyhydramnios have this snowflake appearance, which sort of remind me of the appearance of amniotic fluid in case of acrania, for example. The Carmi syndrome, it's important to know about it because the recurrence risk is about 1 in 4. It's autosomal recessive. And there are a number of genes that can result into Carmi syndrome, but the majority, 80%, is because of this integrin beta 4 mutation. And the clues, you have the family history is important. So also there is raised alpha protein acetylcholine levels, but features of pyloric stenosis, dilated stomach, the polyhydramnios, and the polyhydramnios have this snowflake echogenicity. And in this case, make sure that you look for associated abnormalities, particularly the kidneys and the ear. The jejunal atresia, you have the classic double bubble sign, often after 24 weeks, often presented in the third trimester, and polyhydramnios occurs in about half of these cases. And of course, there's a common association with Down syndrome or chromosomal abnormalities reported in about 1/3 of the cases. But it's important that we know that in the current era of wide implementation of the NIPT or the cell-free DNA early pregnancy, this association is much less. Because often most of the cases of Down syndrome are diagnosed early in pregnancy. So if you have a jejunal atresia diagnosed in the third trimester, the chance of Down syndrome is definitely not 70–40%, is much less, which is what we demonstrated by our data in this article. Don't forget that there is a risk of associated abnormalities, particularly heart, kidney, and vertebra, which is reported in about 10 to 20% of the cases. When you have the diatresia, if they develop severe polyhydramnios and the mother is symptomatic or have short cervix, that will be an indication to offer amnio drainage. We should make sure that we deliver in a center where there is obviously needed intensive care unit and access to pediatric surgery. And there's no indication for delivering early, so usually about 38 weeks, but the risk of preterm birth is high because of the polyhydramnios. There's not an indication to do cesarean section. Survival is more than 95%. And if it's isolated, there's an increased risk of recurrence. But if it is associated with trisomy 21, the risk of recurrence is 1%. Very important is this potential unusual or atypical presentation of cases of bowel obstruction, which is often because of the risk of perforation. Perforation can present as ascites, and the natural history developing meconium peritonitis or meconium pseudocyst. And therefore, what you see on ultrasound, it depends at what stage in this natural history that you scan the patient or the baby. Very important, don't forget testing for cystic fibrosis. And because cystic fibrosis reported in about varying incidence really in case of meconium peritonitis range between 15 to 40%, or reported even some studies in 75%. So make sure that you don't forget testing for cystic fibrosis. Why cases of fetus with cystic fibrosis will have meconium peritonitis is because in cystic fibrosis you have this dehydrated thick meconium that causes obstruction of the lumen of the bowel and therefore result into a picture of bowel obstruction. This is a treatment. This study reported the prenatal treatment of the meconium peritonitis with this urinary trypsin inhibitor. And the idea, the fact that the meconium have digestive enzymes, such as the trypsin, and that causes aseptic peritonitis, and that causes this extensive inflammation that prevent the spontaneous sealing of this perforation, and that the fact that this inflammation causes bowel edema and therefore aggravate the underlying bowel obstruction. And if you have this, we give urinary trypsin inhibitors, so this anti-inflammatory can actually reduce the inflammatory process and therefore improve the picture of the meconium peritonitis. And this is the case that was reported. When you see old images, you see the meconium peritonitis, and 1 day after the treatment with the urinary trypsin, you see there is improvement. In 4 days after treatment, again, significant improvement. What about, is this actually genetic association? And despite the fact there's no really well-defined gene mutation, this case, interesting case that actually highlight this potential of potential inheritance or genetic link. So it's a really sad story. The couple, consanguineous couple, first pregnancy, presented with ascites in the trimester. They did paracentesis. It was meconium stained, and at 28 weeks, it was a picture of meconium peritonitis. So delivered at 36 weeks, and unfortunately, the baby died in the neonatal period. And 8 years later, the couple presented with a second pregnancy. And again, there was a feature of recurrent bowel obstruction and had termination of the pregnancy, and the postmortem confirmed small bowel obstruction. So I'm going to stop here. I hope I had covered the vein of Galen, achondroplasia, and the bowel obstruction. And I'm going to stop here. Thank you very much for your attention, and I'm happy to take any questions. Well, just a huge thanks really to the speakers on this webinars, and just to remind all the delegates that if you have registered for the webinar, that you have access to these recordings until our Congress in Budapest in September, and I really look forward to seeing as many of you as possible. We have several questions and comments from our delegates. So I think some of the questions were related to the first topic, which is about the cardiac anomalies, and the question about the cardiac settings. So Simon mentioned that some subtle So if you have, for example, mild or moderate pulmonary stenosis in the third trimester, you might miss it if you don't have the appropriate Doppler setting, for example. So one of the questions is about what cardiac setting should you have in the third trimester?
Well, I think the best way to answer that question is to understand that the velocities across the arteries, the four chambers, increase each week of gestation. So the PRF, the setting of the PRF is critical. So if you look at the mid-trimester, you set it around about 55 centimeters a second. Up around the third trimester, you're around 65 to 75 centimeters a second. Now, for each patient, this is variable, but just understand that the PRF is so important that you increase that. Otherwise, you're going to miss regurgitant flow across the pulmonary valve, or turbulent flow distant to the pulmonary valve, or in fact, any semilunar or AV valves. So the order of priority is PRF, then your power, and then your gain, in that order of changing settings to get color correct, because picking up valvular lesions is ultimately very reliant on color settings, because most of us can pick up those with 2D where there's obvious dilatation or change in structure or caliber, but it's the power of color in the third trimester I think will improve our detection rate of pulmonary stenosis.
Great, fantastic, thank you. We move on to the second talk in the webinar by Conrado, who focused on the abnormalities in the placenta and the umbilical cord. And maybe, Conrado, would you be able to comment on the significance and the management of umbilical cord cyst?
Yes, thank you for the question, Asma, and the person that asked the question. Well, I didn't have time to cover cysts. Usually cysts are pseudocysts mainly. True cysts are rarer. They usually are more common to see in the first trimester, but they usually tend to disappear over pregnancy, and this is a good finding. We don't need to worry about that. But if they persist, or if they increase in size during the second or third trimester, we might be worried about other associated malformations we have to look for in the anatomy scan, or as early as we can. If there are associated malformations, we have to indicate genetic assessment and look forward to other conditions. If the cyst is bigger, more than 3 centimeters, we have to be attentive to compression and to the growth of the baby as well in the second and third trimester. These would be basic recommendations for cysts.
Okay, and I know the evidence is limited in this area, but if you have an umbilical cord cyst, let's say 5 centimeters, and the baby is normally grown with normal Doppler, normal amniotic fluid volume, would you consider induction of labor or early delivery? Would you let this woman carry on until 40 weeks? What would be your management?
Yeah, I think it would depend mainly on the growth and Dopplers of these babies. I would follow them closely, and if everything is normal, I would follow until maybe 39 weeks, 40 weeks. Looking forward to vaginal delivery, but if any disturbance in growth or Dopplers, I would be more worried and maybe think of delivering a little bit earlier.
Okay, so there are more questions, particularly obviously about the placenta accreta spectrum, and you can imagine there's obviously there's a topic where there are many questions and uncertainties. But I'm gonna bring Fabrizio to the discussion, and there are several questions, and then I'll come back to you, Conrado. Fabrizio, so there is this scenario where you have pregnancy's been fine, and then in the third trimester, you come across this picture of obstructive uropathy. So you have this dilated bladder, you have hydronephrosis, hydroureter, there may be the amniotic fluid might be normal, might be reduced. How would you manage these cases? Do you offer intervention? Do you offer shunt? Do you deliver them early? How do you counsel them?
Thanks, Asma. When it's unilateral, of course, is much easier because the prognosis is not affected, and then you're making the antenatal diagnosis and to program postnatal follow-up. The issue, of course, when it's bilateral and is severe, I don't think that there is a clear answer for that. I think that's the general consensus that shunt in general doesn't work. I think that we tried for so many years and the results are not great. There is the possibility, but I think that's still under research of fetal intervention, especially if there is a posterior urethral valve or eventually a partial valve. If you're having a little bit of amniotic fluid, it doesn't look very bad. But I think that this is still experimental. We don't have this well established. I think that's, to be honest, is more at diagnosis and then a postnatal, final diagnosis and postnatal management with the pediatric surgery team.
Okay, fantastic. Thank you so much. There is a question from Katie C. If during embryology there is a developmental problem of the vein of Galen, why is aneurysm is more likely to be detected in the third trimester, not earlier? Interesting question, and it is true that actually already the abnormality already sort of started or exists from as early as 6 to 11 weeks, but often you see it in the third trimester, not necessarily late in the third trimester. I mean, there have been cases reported from like 25 weeks or 26 weeks to early third trimester, and I suspect it's just the size of the dilated vein of Galen formation. When it becomes large enough to be detected or seen in an ultrasound scan. Or the other thing is that you're seeing the secondary effects, you know, so the hyperdynamic circulation, the signs of heart failure, the polyhydramnias, the dilated or the cardiomegaly and the tricuspid regurgitation, or the extreme case, obviously, of the hydrops. So it's already there from the beginning. But the fact that you often detect it or see it in the second half of the pregnancy, particularly maybe after 25, 26 weeks. Simon, you have your hand up. You have comment.
Yeah, I just, Asma, whether it's an extension of the question, does it matter whether the drainage is via the false sign versus the straight sinus? Is there a differential in the prognostic group, or is there any value in ascertaining whether it's false sign versus straight in terms of the embryology and prognosis?
I don't think so, not sort of from the literature. And I showed these two types, and actually it's more academic, the choroidal type versus the mural type, because actually we don't really necessarily see that on the ultrasound scan, or to some extent make effort to differentiate between the two types. Certainly the diameter of the sinus is one of the predictors. Also, some studies suggested that it's a predictor for maybe worse outcome. But differentiating, I don't think it has significance in determining whether this fetus is a candidate for prenatal intervention or not. So I mentioned about the trial that's ongoing in Boston Children's Hospital in the United States. And if you look at the eligibility criteria or the inclusion criteria, they have not really had that level of granularity in terms of deciding whether, you know, which is draining in which sinus. So why some cases of vein of Galen progress and develop sort of heart failure and have increased perinatal mortality and morbidity, and some of them where you follow up and things are stable and the baby might not necessarily have immediate or need immediate peripartum intervention, it might be because of the fact that whether actually this arteriovenous fistula is draining in the wall or is directly to the vein of Galen. You know, it's interesting, it's academic. I'm not sure that this has a predefined prediction or prognostic value.
Yeah, and I think it's just a small practical point just for the listeners, is sometimes vein of Galen aneurysms can be absolutely tiny. We all showed the big examples with the leukomalacia, the dilated hearts, But in fact, it's very important if you see a tiny little midline cyst and you assume it's a cavum velum interpositum, don't jump to that diagnosis, put on color. And you will find some of these tiny vein of Galen aneurysms. And I don't remember, I've mentioned asthma to see your outcomes because you had 3 groups. They didn't really look great in a sense in terms of, to be in any of the groups. There was a neurodevelopmental delay group, there was the invasive group postnatally, and then those who succumbed. So I always wonder about those tiny little vein of Galen that are managed conservatively after birth. Do they ultimately blow out or do they resolve?
Yeah. Well, I mean, the prenatal detection is about 70%, which means that we don't become
30%.
about a third of the cases during the pregnancy. And it might be that these are the small ones. Also, don't forget that ultrasound scan in the third trimester is not a routine in all countries. And therefore, unless the woman have an ultrasound scan in the third trimester, unless the vein of Galen is large enough to be able to catch your attention when you're going through the axial planes of the head, or you're doing the biometry, or you're seeing the secondary effects to the hyperdynamic circulation, there is a chance that you actually miss it antenatally.
Yeah. Thank you.
Okay, so can't see any other hands. The next question. So we'll go back to the heart abnormalities. I mean, I have a question, Simon. I mean, in terms of the coarctation, and you did very elegantly illustrated the evidence on the fact that the prenatal detection of coarctation is not perfect, and there is a high false positive rate. I mean, what are the consequences of missing coarctation of aorta in the third trimester?
Oh, they're quite significant if there's a focal coarctation, because these babies come back either that some of them are not picked up immediately after delivery, but they may come back and these babies are collapsed and blue. So it is very significant abnormality to miss. And the other group is the group who have a ventricular septal defect, and the VSD closes and say a couple of weeks after delivery and they collapse. So we've had cases like that, coarcs, and I go back and I look at the images and I say, crikey, it really wasn't that striking, and she had a VSD. So it is significant asthma, and I think there's both the group of the false negatives and the false positives. I don't worry too much about the false positive, other than I'm creating anxiety for a significant group. I worry about the false negatives for that reason, that these babies can have significant focal quarks and can go into cardiovascular collapse after delivery.
Yeah.
But okay. I think the biggest problem is managing the false positives, because it's so frequent to find a narrow transverse arch and start worrying about it. We need to manage our anxiety and not transmit that to patients who ultimately, want the duct closes, the aorta is highly vascular and it takes the left ventricular tract and it expands into a normal functioning aorta. So I think we need to manage the false positive rate, which in the third trimester in some published series of 80%. We need to manage how we convey information to patients.
Okay, brilliant. We have many questions. So I'm going to jump to Conrado and ask about the placenta accreta spectrum. Do you do routine transvaginal ultrasound? And what about the ultrasound scan or MRI? And I appreciate, obviously, your talk was not necessarily focusing on placenta accreta spectrum. So, we wouldn't expect you to go through all these details, but certainly I think it's a common question.
Yeah. So they asked for my preference. My preference is ultrasound for sure. I'm a sonographer,
without
not
being biased
a
at all.
radiologist.
Without being biased.
But I have to say that if we look at the literature, we are going to see similar accuracy for ultrasound and MRI, but taking into consideration that these publications are done in tertiary centers by experts in the field with high-end machines. So if you know what you are doing, if you are good in that, you can use ultrasound, you can use MRI. But we have to say that we usually have many difficulties for availability of MRI in many centers. We don't have specialized professionals to look for placental abnormalities in MRI in many centers. So I think my impression is that we need to screen universally for PAS, for low-lying and previa and placenta previa during pregnancies using ultrasound. And if the patient has a low-lying or previa, and if the patient has a previous C-section, this patient has a positive screening for PAS using ultrasound, simple ultrasound, and this patient needs to be referred for the specialist to confirm or rule out this diagnosis. So ultrasound has a major role. We are going to use MRI mainly in cases where we have difficulties using ultrasound, posterior placentas with posterior uterine scars, parametrial involvement, high BMI, but well, using transabdominal plus transvaginal, I don't remember the last time I needed to do an MRI. We don't do in our center.
Yeah, so I think that's, yeah.
Yeah, just a quick comment. I completely agree with Conrado, but one thing that we cannot forget that MRI is also operator dependent, right? It's not because all the imaging packaging is there that you have all the information. Depends on the operator. One thing that we are doing at Monash in Melbourne was reading the MRI together with the ultrasound images and doing the correlation, and definitely improves diagnosis for difficult cases. But I completely agree with Conrado, main diagnosis by ultrasound.
Yes, and just maybe to use the opportunity to highlight the recommendations from the Isuog guideline, the third trimester, is that we rely on ultrasound scan, and the role of the MRI, as Conrado mentioned, mainly really in things like posterior placenta, parametric invasion, and maybe difficult to scan patient, or someone had myomectomy and you're not really sure where, don't have access to surgical nodes, where is the incision? So, in selected cases. Simon, do you want to add comment? Just conscious of the time, a lot of questions.
Yeah, I'm moving on to a different topic, just on the time factor, Asma. And it's for you, and it's a nice question because there are two questions. One is bowel obstruction largely depends on the viability of distal bowel to the obstruction. Is ultrasound any good in assessing that? And then my second question is from me, Asma, is how good do you think we are distinguishing small bowel versus large bowel obstruction?
I don't think we're really very good in even diagnosing bowel obstruction prenatally, and we published on that, and it's not us as in scanning. It's just the fact that the finding of dilated bowel on its own is not a very good predictor or prognostic or diagnostic of bowel obstruction. And the same applies to the polyhydramnios on its own. It's not a reliable ultrasound marker of bowel obstruction. I think finding both, so if you have both bowel dilatation and polyhydramnios, yes, it's more likely that you have bowel obstruction. And in fact, a large proportion of cases of bowel obstruction, whether duodenal atresia or ileal atresia, for example, are not really detected by ultrasound scan. So, and therefore, I think it's important that we realize the limitations of the tool that we have, and also that the timing of the ultrasound scan that we have. And I think that's really important also in terms of medical legal implications. So, if a patient the baby's born and then there's bowel obstruction and, well, actually why it wasn't picked up antenatally, well, actually ultrasound scan is not really very reliable in diagnosing bowel obstruction. I think it's an important fact to know. The question about the small bowel versus large bowel, I think there are obviously and I think I covered them in my talk about how do you differentiate small bowel and large bowel.
Yeah.
But sometimes it's not that easy. It's not that straightforward, especially when you have a polyhydramnios and distended fetal abdomen, which is full of really dilated bowel. So sometimes it's not that easy. But certainly the general rule, the more severe the polyhydramnios, the more proximal the obstruction.
Yeah. And I think also, Asma, the point you made about those scenarios where you see bowel dilatation, whether you're uncertain whether it's large or small, the importance about following them up to see whether they progress is probably a key take-home message, isn't it, for people listening in? Because if there is truly obstruction, it's something in the next scan 2 or 3 weeks later, they say, oh yeah, it's bowel obstruction. Asma, a quick question I want to just throw in because I'd like to know your answer. is the question that's come in. I'll see if I can find who asked it, but for a femur length less than the 5th centile, how do you counsel patients? And I think this is a question that a lot of people like to know. Whose chart, what centile?
Yeah.
When do you raise the when do you raise the flag, and how do you raise the flag?
Yeah. I mean, I saw the question, and actually, to be honest, I said, well, that's not really the subject of this webinar, because we're not really covering skeletal dysplasia to some extent, but it could be with achondroplasia, of course. So that, yeah, to some extent, it may be under this auspice. But I think the typical clinical situation is that you're scanning someone in the 3rd trimester and you finding a short femur. I think which chart to use, I think that's another topic. And to some extent, there's no really evidence to say there's one chart is better than other in terms of femur lengths. There's a whole controversy about which biometry and which estimated fetal weight chart, but that's not the subject of this webinar. So
which chart does Asma Khalil use?
Oh, it depends which hospital. I work in a number of hospitals, so it depends which hospital. And you've got obviously the Chetty charts, you've got the Interros, you've got a number of charts. And actually, I really think what you really, I think if the femur is really short, I think it will be short on whatever chart you use. And therefore, once you have that, you really need to have a systematic approach. So you need to rule out things like skeletal dysplasia, and therefore you need to look for the signs of skeletal dysplasia, the mineralization, is the bones are bald or not? What about other features of skeletal dysplasia, the size of the chest, the size of the head, because you often have large head circumference. The assessment of amniotic fluid, associated abnormalities. So you just need to be really very systematic. And once you say, well, it's unlikely to be skeletal dysplasia, what was the femur in the 2nd trimester? Was it also short, or was it in normal range? And how short is short? Because cases with achondroplasia in the 3rd trimester, this femur is not just sitting on the 10th centile or the 5th centile. This femur is really short. Yeah. And I mentioned about the angle, and certainly I would say I've never really come across a baby with achondroplasia that the angle was normal. It's often a function of angle. But and maybe there are always exceptions, rules, it's nothing 100%, but certainly I think most of the cases we often in our MDT we will look and say, what's the angle? Is the angle is wide or not? So this is one thing. And then obviously think of possibility of Down syndrome, for example, because it could have just a slightly short femur, not very short. So you're looking for what was the risk of chromosomal abnormalities, and also look for the height of the parents. I mean, is it constitutionally that the parents are short? Also, it could be an early sign of growth restriction, and therefore look at the uterine Doppler, look at the placenta, the history of the previous pregnancies, the history of the risk of if she had risk of preeclampsia, for example. So just having a systematic approach. Can you always be sort of reliably exclude or rule out cases of skeletal dysplasia? And the answer is no, because sometimes it's actually really subtle.
I think we need to have a webinar on the topic, Asma, but that's a very helpful, quick summary. And if you don't mind, I'd like to come back to the very first question I asked Fab. Is kidneys are difficult to see in women with large BMI, full stop. So you do a scan at 26 weeks, and now you can see that one kidney is missing. Do you get into a discussion, given your figure of 10% with genetics, do you get into a discussion about offering invasive genetic testing in that setting in the 3rd trimester?
I think that depends of the 1st trimester screening that this patient had, because this association is with the major chromosomal issues is trisomy 21. Is trisomy 18. Of course, most of the 18s, they have major malformations, but we all saw cases with very subtle malformations or even eventually a normal scan with trisomy 18 and Turner syndrome. If this patient had NIPT as a screening, I don't offer invasive. If she had 1st trimester combined screening or didn't have a screening, I offer invasive, but I counsel that's a low, generally is a low association, but I offer the procedure.
Yeah, thanks very much, Fabrizio. And I was also pleased to see that the pelvic kidney has no association, which is sort of reassuring to see that. But again, you make the point, make sure there's no vactral or vater. Yeah. Thanks very much. Asma, do you want to wrap up? I think we're a little bit over time. Are there any other pressing questions that you see you want to quickly finish off on?
I mean, I think we did cover sort of most of the, I would say if you join up the questions and have common themes. So we did cover sort of most of the, the question about obviously urinary obstruction, intervention or not. I think some of the questions already have been covered quite comprehensively in the talk, so there's no point in repeating the questions.
One maybe quick close.
Yeah.
One quick closing one from Conrado. Conrado, you see a single umbilical artery. I know it's where it's a third trimester talk, but it is a question here. You see a single umbilical artery as an isolated finding in the mid-trimester. Do you see any grounds to bring the baby, mother and baby back for growth assessment, number one, or two, cardiac assessment, or three, any other reason? The question, Conrado, if I can qualify it, the question comes in stating that the Society of Maternal-Fetal Medicine recommends no additional testing for a single umbilical artery. I'd just like to know your thoughts.
Yeah, no, I think it's similar to what Fabrizio has just said to kidneys. I think we need to look back to the first trimester screening for aneuploidies if everything was well at that point. If you have a normal NIPT, if you have normal, if it's really isolated, no other abnormalities or morphology, I would just see this patient maybe one more time in the third trimester to guarantee that there are going to not to be any growth problems. So maybe we're going to see this patient around 32 to 36 weeks. But if you have abnormal first trimester aneuploidy screening, if you have associated abnormalities, we have to investigate with invasives.
And Fab and Asma, growth cardiac, because we in Melbourne, in our unit, we see a single umbilical artery, we bring back for cardiac assessment, but I'm not sure the evidence is there for that. Do you have any comments?
We don't actually routinely do cardiac assessment. We do monitor their growth because the association with small for gestational age. I don't think the association really with cardiac abnormalities is that robust. So we don't, and certainly again in isolated single umbilical artery is not really an indication for invasive testing, for example, or prenatal diagnosis. If it is an isolated, of course, if it's associated, that will be an indication. And just maybe before, I'm conscious of the time, certainly I think some of the questions really highlight the fact that, what about medical legally? Because there's some of these abnormalities are only detected in the third trimester and not detected in the second trimester. And whether we should put a disclaimer, a bit like, many of us will have a standard disclaimer that ultrasound scan alone does not rule out chromosome abnormalities or genetic syndromes. Should we be saying, following, say, the anomaly scan at 20 weeks, that there are some fetal abnormalities that are only detected in the third trimester or not really detected at the time of the routine anomaly scan in the second trimester? And that's an interesting interesting concept to bring to the discussion. I don't think I see that routinely, or sort of have come across that in any of the, the clinical practice, at least in the UK. But I think it's a really good point. I mean, this is Dr. Manoir, who suggested, do we have to give a disclaimer in our report that all of these anomalies just now being discussed are only detected later in pregnancy? Because it is true that some parents will question, will say, but I had few ultrasound scans before. The doctor told me everything is fine. Now you're telling me that the baby have, brain abnormality, for example, or kidney abnormality. It'd be interesting to hear your views.
If I could just closing comment, and first of all to thank Samsung for the support of this webinar, but also for all of those listening in. Realize that it was Asma who put this third trimester guideline together with Conrado and others, and I think it's a guideline that's a very important read, and I think it's a little bit of a game changer as to what we do in routine clinical practice. So I encourage you to go to isuog.org and put in third trimester guideline and read it. And I've put my very last question to you, Asma, having been the prime author on the guideline, is whether you recommend doing a growth scan at 32 to 34 weeks or a growth scan at 36 weeks.
Well, the data, I think, is quite clear. I think if you really, if your aim is to improve your ability to diagnose small babies or large babies, it's better to do it later in pregnancy, so 36, 37 weeks compared to 32 to 34 weeks. But if you're looking at abnormalities, which is the subject, really, is the focus of this webinar, it is true that actually looking at the baby's anatomy at 32 to 34 weeks is much easier and more practical and more sort of feasible when you do the scan at 32 to 34 weeks compared to 36 to 37 weeks. I mean, 37 weeks, the head is low in the pelvis, and sometimes it's really difficult unless you do transvaginal ultrasound scan. You know, if the baby's spine is anterior, and there's a lot of shadows by the ribs, you might not be able to get the perfect views of the heart. So I think certainly particularly if you have a couple that had a previous baby that has an abnormality and you're doing a scan in third trimester, it's better to schedule it at 32, 34 weeks. But if you actually saying baby is small, had a previous small baby, and you're monitoring this pregnancy because you want to see the baby small, or if it's potentially a large baby and you want to make a decision whether to offer induction of labor or early delivery or not, in this case, do the scan later because it's likely to be more accurate and more reliable.
But Asma, can I push the high risks to the side and ask you to pin you down to one scan? 10% of babies fall below the 10th centile. The incidence of fetal malformation in the third trimester is less than 1%. You're balancing up. So if you're given the one scan, which would you choose?
I think if I'm given one, well, number one, and we did say it, and I know it's controversial. And
you could do it at 34 weeks.
No, it's upset some people, is the fact that there's no evidence to say we must or we should offer routine third trimester scan. I personally actually advocate of the third trimester scan. That's why we actually wrote an Isuog guideline. But if I'm the health minister and I only have very limited budget because our economy in the UK is so bad, in this case, I would do it one scan at 36 to 37 weeks, because if I detect small baby and you plan the delivery, you potentially avoid the risk of stillbirth, and therefore you improve the outcome. While actually you could argue if you detect the baby that has an abnormality, well, unless this abnormality you can offer peripartum intervention that improve the outcome, will actually, that's not necessarily will be improvement in outcome.
And that's the key point, isn't it? Yeah, that's the key point. I mean, Conrad and Fabrizio, do you agree? Are you on the same page on that?
Yes, 36.
36 weeks. Yeah, and maybe Asma, it's a very relevant point we didn't discuss. You make these diagnoses late in gestation. Is there any evidence that you improve outcome for any abnormality? And I just don't think the evidence is there, right? I mean, I always think anecdotally, you make a diagnosis of TGA. I mean, that's for sure going to be a value improving the outcome for that baby. But broadly, when you look at the data in terms of proving perinatal outcome, the detection rates may be there, but the improvement the data isn't there just yet. I might stop talking, Asma. Hand you back to make the final. You have the conch, make the final word.
Well, I mean, can I say something? I think there are so many questions and comments that, if we go through all of them, we need another hour really to be able to cover everything. But really just to say huge thanks to the experts and speakers who joined us today. It's not just joining for the 2 hours of the webinar. There's a lot of work that go behind the scenes in preparing the talks and recording them. But also we mustn't forget that the Isuog team, they do a huge amount of work to ensure that these webinars that deliver educational material and they are accessible to everyone, and the recording is available. So thank you so much and well done for another successful educational event. The AV team, that they make sure everything is run smoothly, and also of course for our sponsor Samsung for this webinar. So on this note, I'd just like to thank you all, and I hope that you enjoy the rest of your day or your evening, depending on where you are. And I'm sure there will be other educational events and webinars in the next few weeks. And again, just to remind you, don't forget to register for the Isuog Congress in Budapest. And I really look forward to seeing you there.